Welcome, and thank you for joining us this afternoon for today's Astera Cancer class, Low Platelet Levels and Advancements in Treatment. My name is Kathy Chern, and I'm a Consumer Health Librarian at East Brunswick Public Library. Today's program is brought to you by Astera Cancer Care and the library's Just for the Health of It initiative to promote community health and wellness. Our speaker today is Dr. Marcus Porcelli, board-certified medical oncologist and hematologist. Please be aware that this talk is being recorded. Please keep your microphones muted and your webcams off. When ready, the recording will be available for viewing at ebpl.org/YouTube. If you have any questions, please type them into the chat box. Our speaker will answer questions at the end of the talk. Please be aware that the doctor cannot provide medical advice to attendees during this program. And without further ado, I'll turn things over to Dr. Porcelli.
Thank you, Kathy, for that introduction, and welcome everybody. Thank you for taking the time out to learn a little bit about our bodies and how they work. I thought speaking about thrombocytopenia was timely because it's gotten a lot of publicity lately with the COVID vaccine. And I thought to myself, gee, I wonder how many people really know what thrombocytopenia is. So I thought it might be a good topic to discuss. Thrombocytes are another term for platelets. And interestingly, in my entire career, I don't ever remember referring to platelets as thrombocytes. It's always been platelets. But penia, as you remember when you took Latin in high school, it means lack of. So putting them together, thrombocytopenia means a lack of platelets. I think it has a better ring to it than plateletpenia, which sounds like a board game or something. So let's go in a little deeper. And can you advance this? That's good. Thank you. I thought we'd give a little definition about what platelets are, what their function is. And then we'll talk about the causes of low platelets. And then we can talk about some of the clinical manifestations. And then finally, to wrap up, we'll discuss some of the latest treatments. Platelets are the smallest of blood cells. They are produced in the bone marrow from a parent cell that's called a megakaryocyte. And they number anywhere from 150,000 to 350,000. There might be some variation from lab to lab, but that's generally the range. They don't live very long. They're about 7 to 10 days. That's their lifespan, and then they die off. The megakaryocytes have receptors on the cell surface for an intermediary called thrombopoietin. It's kind of a mouthful. We call it TPO for short. And when the thrombopoietin engages in the receptors on the megakaryocyte surface, that gives us replication of the megakaryocytes. Numerous cells with the pale centers, those are red blood cells. They look like Cheerios. Those are the cells that carry our oxygen to the tissues and pick up carbon dioxide, which is a byproduct of metabolism, and bring it to the lungs and get rid of it and take in more oxygen and bring it back to the tissues. The other three large cells there are white cells. As you know, they help fight infection. They also are our memory banks for our antibody production. And the little dots that you see at the bottom of the slide, those are platelets. So you can see how small they are. And these I can tell are mature because they're very dense and they're really tiny. Can I have the next slide, please? This is the platelet parent cell. Remember the megakaryocyte. This is found in the bone marrow. It is the largest cell in the bone marrow. And it is thought that the platelets break off from the periphery of that cell and gain access to the bloodstream. Next slide, please. Here's a slide that shows a blood smear. And if you look, it's not a very good slide. I apologize. I couldn't find a better one, to be honest with you. But if you look we're not seeing any of those, maybe one or two little dots that can account for a for a platelet. But for the most part, they're absent. So this is typically what you see in a patient that has a very low platelet count. We see one white cell, and the majority of those cells are the red blood cells. Next slide, please. So I think we should talk a little bit about the function of the platelets, because I think if you understand how the platelet works and what its responsibilities are, then it's easy to understand the clinical manifestations that will occur when the platelet function is low, or if the platelet function is interfered with by many medications that are available today. And we'll talk a little bit about that. So even though they're the smallest cell in the blood, they play a huge role in helping us clot. So they are the first line of defense against any bleeding. We tend to think of our blood vessels as tubes, like a garden hose, or if you ever take a wire with the plastic coating and you strip it and you have that nice plastic coating. But your blood vessels are made up of cells, just like the rest of the body. And every now and then, there might be a hole between those cells might get a little big. So that's the job of the platelets. They kind of circulate in the blood, and they look for those holes that get a little too large. And also, if there's trauma or surgery where you actually have a cutting of the tissues, the platelets recognize those defects in the blood vessels and hone in there to try to stop it up. As they do that, they throw out extensions of the cytoplasm, which are called pseudopods. And that has the function of trapping other platelets in the area. At the same time, it's releasing substances that call more platelets to the area, and also substances that cause the blood vessels to constrict a little bit. That way there's less blood flow to that region. And the ultimate product is what's called a platelet plug. And this plug clogs up or fits in that hole in the blood vessel wall, or the damage from the surgery or trauma. And then the second part of clotting is the actual formation of a clot. And you have these clotting factors in the bloodstream, but they can't connect just floating around in the bloodstream. They need something to build on. And that's the second important function of the platelets, is they form a scaffold. That platelet plug forms a scaffold onto which the clotting factors can connect and ultimately form a clot. So that's basically the function of the platelets. And just as an aside, there's medications that affect the platelet function that are very useful. Most of our heart doctors and our neurology doctors, they use drugs that can interfere with the platelet function to their advantage, because it's well known that patients with heart disease, or patients who have had strokes, or minor neurological impairments, what are called like a TIA, those patients benefit from drugs that interfere with platelet function because of better outcomes. There's also a bunch of medicines that are over the counter that interfere with platelet function, but they're not used for that reason. And I'm sure you're all aware of them. Who hasn't taken an aspirin in their life, okay? And a whole bunch of other drugs that are called non-steroidals. And they're anti-inflammatory, but they don't have the structure of a steroid. And they're over the counter, and I'm sure you know what they are. They're ibuprofen, Aleve, naproxen, Metaprin. The pharmaceutical stores, pharmacies, and even now the supermarkets, they have a whole row of these drugs. Aspirin is unique because once a platelet is exposed to aspirin, it irreversibly affects its function. So it doesn't work anymore. The other drugs, they interfere with the function, but once you stop taking them and the drug is cleared from the body, the platelet function returns. So that's why when, if you need a colonoscopy or a catheterization, they always say, oh, make sure you're off aspirin for about a week or 10 days, because you have to wait for those poisoned platelets to be metabolized and get out of the circulation and are replaced now by fresh, healthier platelets. The other drugs, once you stop the drug and it's clear, the platelet function will return. May I have the next slide? So now we understand a little bit about their function, and we can talk about some of the causes of thrombocytopenia. There's one cause that I want to talk about is called pseudothrombocytopenia. This is, again, going back to Latin, is a false thrombocytopenia. And what happens here, it's a laboratory artifact. And what happens is the platelets clump once they get into the test tube. There's a lot of different theories about why it happens. Everybody puts their little spin on why, but it doesn't really matter because in your bloodstream, they're not doing this. In their bloodstream, they're not clumped, but in the test tube, they're clumped. So when it is put into the machine reads the cells by their size. So it sees these clumps of platelets. It's not sure what to do with it, so it kind of ignores it. So you typically get a low reading. But what's typical of pseudothrombocytopenia is the platelet count not very low. It usually gets around 90, 100,000. So when I see platelet counts that are low, but not very low, my first thought is, gee, is this pseudothrombocytopenia? Because remember, it's just a laboratory artifact. It has no clinical consequences. However, every time you have your blood drawn, it's going to raise a few eyebrows. Can I have the next slide, Kathy? Here's a good example, and it's very simple to do because you put a drop of blood on the slide, put it in a stainer, go have a cup of coffee, come back, look at it under the microscope, and there you see it. You can see these little platelets all stuck together about the same size of the cell next to it. Can you have the next slide, Kathy, please? And this is just another example, and it's very easy to diagnose. See, then you just look at it under the microscope, scan around, and you say, oh, it's really not, it's a false low platelet count. So, and again, no clinical consequences. It's not clumped in the bloodstream. They're healthy platelets. But again, whenever you get a blood test, there's kind of like, oh gosh, platelet count's low. Can we go back 2 slides? Okay. So that brings us to medications, because by far and away, medications are probably the most common cause of low platelets. And we can broadly make the medications into 2 categories. We have one where it's an anticipated side effect of the medication. And the best example I can give is chemotherapy, because chemotherapy or radiation therapy, they target the platelet parent cell. And remember the megakaryocyte. They destroy those cells. So when your mature platelets eventually die off, there's nothing to take their place. So then the platelet count goes down. And then the other way that medications affect the platelets is thought to be with the immune system, but we don't understand why certain drugs in certain patients result in a low platelet count. In other words, we can give Mr. Jones and Mr. Smith the same drug, but why does Mr. Jones develop a side effect of low platelets, whereas Mr. Smith has no problem? We haven't quite understood that yet, but that's called an idiosyncratic reaction. And there's a lot of medications that have been reported to cause low platelets, but it's not an anticipated side effect like you would with chemotherapy, because with chemotherapy and radiation, you can almost bank on getting a low platelet count. Okay, so the next is infections. We know certain viral infections can cause a low platelet count. Probably the best known is HIV disease can cause a low platelet count, but any type of severe infection will affect the platelets. And it's thought that it's really just a part of the body's response to trying to fight off the bacteria, and the platelets get destroyed in the process. I'm going to skip the ITP. I'm going to go right below that to the liver disease. Remember earlier on, I talked a little bit about the thrombopoietin, or the TPO, that stimulates the megakaryocytes to produce more platelets. Well, in liver disease, we have a twofold problem. We have one, the thrombopoietin is mainly made in the liver. So if your liver is not working well, it may not be making enough erythropoietin. So those megakaryocytes, or the megas as we call them, are not getting stimulated. And as a result, they're not going to thrive. They're not going to multiply like they normally would. So that can cause the platelet count to go down. There's also the spleen. The spleen is really like a big lymph node. It's a little bigger than the size of your fist. It's tucked up under our left rib cage. When we're young, it's very important. It helps our immune system to mature. But as we get older and your immune system is mature, its main function is a filter. It doesn't like anything abnormal in the blood. But when you have conditions affecting the liver, the pressures in the liver go high, and the vein that drains the spleen into the liver, that pressure is high. So that backs up into the spleen, and the spleen can enlarge. And as it gets bigger, it filters more. So the spleen, a large spleen will filter the platelets as well as the white cells. So patients will also develop a low platelet count, from that. So with liver disease, we have the problems with the spleen getting a little large, and we have the lack of the thrombopoietin. Now, of course, the last topic, we'll go back to ITP in a moment, but the last one on the list here is a blood disease. Of course, blood diseases can affect the platelet count, but they generally don't single out the platelets. They usually will affect all three cell lines. The patient will be anemic because the hemoglobin is down. The white blood cell count may be very, very high in cases of leukemia, and also the platelet count can be low in these blood disorders. So it's very unusual for a blood disease just to single out the platelets. So let's go back to ITP for a moment, because that's probably the most studied of these conditions. In the old days, not that long ago actually, the I stood for idiopathic, because we really weren't quite sure what the cause was. And remember, thrombocytopenia, low platelets, purpura. Purpura, again, is a general Latin, a general term for any kind of bleeding into the skin, okay? Now, however, we think that the immune system is the culprit. For some reason, the patient is developing antibodies against their platelets. So it falls into the category of an autoimmune process where the immune system is attacking the body. That's what the autoimmune means. So in this case, they're producing platelets antibodies, and these are coating the platelets. And as these antibody-coated platelets go through the spleen doesn't like anything abnormal in the blood, and it has receptors for a component of the antibody. So when those antibody engages in that receptor, the platelet is removed from the circulation. So that's felt to be the theory for the ITP. It occurs in children and in adults. It's not that common, but it's well described. And in children, it tends to be an acute form. In other words, the child is fine, and then the next day they're covered with these bruises or gum bleeding. Whereas in adults, it takes a more chronic or insidious pace. The patient may notice some easy bruising, and then they'll just kind of pass off as, oh, I may have bumped myself. But then the count gets below a certain point, and they'll start to have other manifestations of bleeding, and then they'll seek medical advice. With children, it tends to go away about 90% of the time. But with adults, it only goes away about 10% of the time, and most of the time takes a chronic course, and most patients will need some type of treatment to keep the platelet count in a range that'll keep them safe. Okay, may I have the next slide? Oh, I'm sorry, we have to go past the clumps. Okay, so let's talk a little bit about clinical manifestations. The only thing we see with low platelets is bleeding into the skin. Now, the key thing is it's superficial bleeding. So you'll see bleeding into the skin, you'll see bleeding into the mucous membranes, what's sometimes called wet purpura. So you have like bleeding on the tongue, on the inside of the cheeks, and also the eyelids. The inside your eyelids, those are mucosal surfaces, and those are referred to as wet purpura. Now, the clinical manifestations of the ITP can be anywhere from just a low platelet count on a blood test to platelets down to the single digits, where the patient will get gum bleeding, nose bleeding, and they won't stop until they get help. And then you have everything in between. And you can live a normal life with a low platelet count, provided it's not too low. In fact, you can do surgery on the chest if the platelet count is 75,000 or higher. You can do surgery on the belly if it's 50,000 or higher. For any kind of surgery on your head, they like it 100,000. So I have a bunch of patients, and I'm sure other doctors who see these types of patients have. Their platelet count runs low, but it's not dangerous, and they don't require any medications. They may, however, need their platelet count to go up a little bit if they're planning to have like a colonoscopy or they need to have surgery. There's ways we can get the platelet count up to allow them to safely get through those procedures. So the other type of manifestations we see are petechial, which are really pinpoint hemorrhages. These look like the size of a pinhead. They're bright red, and when you press them, they don't go away because it's actually bleeding into the skin. So it's not like a dilated blood vessel that you'll press and it'll blanch. It's actual bleeding into the skin. And of course, easy bruising, that's just ecchymoses is the fancy term for that. And you can have nosebleeds, epistaxis, oozing gums. Women who are menstruating, their menses may be very prolonged and heavy. And sometimes you can see blood in the urine, and also sometimes blood in the stool. But remember, it's superficial, skin, mucous membranes, as opposed to patients with clotting disorders like hemophilia, where the bleeding is deep. Those patients bleed deep in their muscle and their joints. So it's a little different type of bleeding. Can I have the next slide? Here's an example of petechiae. This is the lower legs because the pressure in the veins in the lower legs is a little higher than in the upper body. So it tends to manifest itself first in the legs. And you can see these little red dots scattered about the body. And that's a very good example of a petechiae. Next slide, please. Here's an example of what we call wet purpura, where we have bleeding involving the mucous membranes. You probably call them blood blisters. We still do, but you see these two lesions on the tongue and one lesion on the inside of the lip. So that's a good example of a wet purpura. Next slide, please. This is just a bruise, ecchymosis to be more formal. So those are basically some of the clinical manifestations, but you can also get catastrophic bleeding. I don't know if you're aware, but some time ago, when the COVID vaccines were first being issued, there was a doctor down in Florida, and that's what kind of led to the thrombocytopenia getting some publicity, who developed a very severe case of ITP. He did not respond to the usual measures. And unfortunately, he passed away because he had the most feared complication, which is a bleed into the brain, what we call CNS bleeding. That certainly happens. Fortunately, it's not very common. I have to be honest. I've not seen that in my career, so I'm happy about that, because sometimes these conditions can be very resistant to treatment and can be very difficult for the patient. Okay, next slide, please. Okay, let's talk a little bit about therapy. Of course, if you think the low platelet count is coming from a drug, we just stop the drug. There's sort of a misconception that if you stop the drug, the next day the platelet count will be normal. It can sometimes take a week or so, but that would be the main thing. If you think a drug is causing it, then you need to stop that medication and give it a few days. If that's the cause, it'll eventually improve. If the patient has a severe infection, then you do what you can to treat the infection and support the patient however they may need intravenous fluids, perhaps medication to keep their blood pressure at a good range, whatever it takes to get them through the infection. A little more difficult with liver disease because a lot of liver diseases don't have very good treatments, so it becomes more of a supportive measure. But in patients with ITP, if you feel that their platelet count is low enough to warrant therapy, then we have a few options. Steroids, as far back as I can remember, have always been the first line of therapy. And the theory is that the steroids decrease the antibody production. So by decreasing the antibody production, you're not getting these antibody-coated platelets that are being removed by the spleen. So you would put the patient on usually prednisone, 1 milligram per kilogram of body weight, and then monitor their platelet count. Once the count improved, you would kind of ride it out until it went to normal, or sometimes it'll improve, but it might just kind of plateau at a certain level and won't go any further. Then you would try to start to taper the prednisone slowly, and hopefully that the platelet count will stay up. The advantages of prednisone, it's an old drug, it's rather inexpensive, and it's all pretty much outpatient therapy. But prednisone, it has a lot of side effects. It's really a wonderful drug, but it's a drug that you really don't like to keep the patient on for any length of time, nor don't like to keep them on like high doses because of the side effects. It's can soften the bones. It can destroy the supporting structures of the skin, creates havoc with your blood sugars, increases your blood pressure. It results in a redistribution of body fat. So these patients typically have like a hump back and a thick neck. So it's not a drug that you want to like to keep the patient on for any length of time. Another good treatment is intravenous immunoglobulins, which is called IVIG. Now, if we remember going back to the spleen that doesn't like anything abnormal in the blood, the cells on the spleen have these receptors, and the antibody engages in those receptors. So by giving very high doses of antibodies, you basically flood those receptors. So there's no receptors available to interact with the with the antibody-coated platelets. So basically they kind of like get by, okay? But once that antibody and receptor engage, the antibody is metabolized, and eventually that receptor is going to be free again. And when the receptor is free again, it's going to start taking the platelets out again. So the IVIG, it's good because it's the fastest way and probably the most secure way to get the platelet count increased. Sometimes as quickly as the next day, you'll see the platelet count go up. But it's going to peak. Its response is going to peak at about 10 to 14 days. And then as those antibodies are metabolized, we're going to see those receptors being free again and result in taking away more of the platelets. What the downside is, they're intravenous immunoglobulins. They're someone else's immunoglobulins. They're not yours. So your body may recognize them as foreign, and you may have like a risk allergic reaction, which could be anywhere from a little itching to trouble breathing to loss in blood pressure. So, that sometimes happens with these drugs. They're a long infusion, so it usually ends up being in the hospital, and they're very expensive. But they're the most secure way and the fastest way. So if you need to get that platelet count up in a hurry, if the patient is having significant side effects from the low platelets, or needs to have surgery that can't wait, you would use your IVIG. Another drug in the armamentarium is rituximab. Rituximab is a remarkable drug. It's been around a long time. And it's one of the first drugs that are called targeted drugs because they actually specifically attack a certain protein on the surface of the cells that are responsible for antibody production. Chemotherapy does not distinguish between good and bad cells. But the rituximab will only attack those cells that have that certain protein. It's called CD20 on the lymphocytes, the cells that produce the antibodies. So it's given once a week, times 4, give 4 treatments. And the nice thing about it is it can sometimes result in these very long remissions, and the patient won't have to take any medication, and which is a little nicer, you know. The last one on the list here is a splenectomy.
Oh, I'm sorry to interrupt you, Dr. Porcelli. Your sound cut out in the middle of your explanation for rituximab.
Oh, okay. I'll repeat it. I'm sorry. Can't get that phone off. Sorry. Rituximab, it's a monoclonal antibody that is designed to attack the lymphocytes that are responsible for the antibody production. So by targeting those cells, it decreases their function, so they stop making the antibodies. So it's an effective treatment. Doesn't really have FDA approval for the ITP, but it's very commonly used. And it's given once a week times a total of 4 treatments, and it has the promise of putting the patients in remission for a long time. So I like to try to incorporate that if I can get insurance approval, because once you finish the course, there's the potential that it'll go into remission for a long time and the patient will not have to take any medications. So the last one on the list here is a splenectomy. And this is a surgical procedure. And when I first started in this business, this was very commonly used because remember, the spleen is where the antibody-coated platelets are removed, but it's also felt to be a spot where most of the antibodies are produced. So by getting rid of the spleen, you attack this twofold. You know, you decrease antibody production, but you also decrease the site of removal. But it's a surgical procedure, and you know, it's really been put on the back shelf because with these newer treatments, the rituximab and some drugs that I'm going to talk about in a few moments, we really don't do splenectomies anymore unless it's a patient that's not responding to the usual methods. Then as a last resort, you may want to do the splenectomy. May I have the next slide? So these are some of the newer drugs that are useful now, and they're really quite effective. And with a little change in thinking is because up till now, we've been focusing on trying to decrease production of the platelets, right? We're trying to get rid of the antibodies. We're trying to get rid of the areas where the platelets are removed. But then someone thought of, well, why not stimulate the platelet production instead of trying to remove the sites of removal? And that's where some of these drugs come into play. The L-trombopag or Promacta, this acts like the thrombopoietin. It stimulates the receptor and increases the production of the platelet parent cell. It's a very effective drug. It's taken a pill once a day, and I've had very nice responses. In fact, some patients, we cut the dose down, the response is so good, and I have a couple of people that just take a pill once a week, actually, or sometimes every other day, because the response is really very favorable. And remember, earlier we spoke about you don't really need a normal platelet count to have a normal lifestyle. You just want one that's not too low, where you're going to have a lot of bruising or bleeding gums. So if you can try to keep the platelet count above 50,000, that's really your target. The next drug is the romoplastin, very similar to the Promacta in its way it works. The only drawback, or maybe not a drawback, but it's injectable. It's a subcutaneous shot, much like a diabetic gives them insulin. It's just a little shot under the skin once a week. So it's like a patient preference. It's no more or less effective than the Promacta. But if you're rather just take a shot once a week and be done with it, then that may be the drug that you would prefer over taking a daily pill. The last one I'm going to talk about is the fostamatinib or Tavalisse. And remember the receptors on the cells in the spleen? This drug decreases those receptors, or what we call downregulate those receptors. So there's no sites of removal of the antibody-coated platelets. So that's another drug that has been very effective. The only downside with this drug, I think, is it's twice a day. So if you have an option of ask a patient, do you want to take a drug once a day or twice a day? They're going to say, I want to take it once a day. So that's the only downside there. So that's my brief but spectacular take on thrombocytopenia.
All right, thank you so much, Dr. Porcelli. All right, so we're going to open up for Q&A at this point. So if you have any questions, please feel free to type into the chat box. And we did have a question that had been emailed earlier. What's it? Let me see. Results of my latest blood test puts my platelet count at around 124,000 per microliter. I know that's low, but I started Plavix and my count has been low. Should I be concerned?
No, I don't think so. If you remember earlier, we talked about pseudothrombocytopenia. When I see a platelet count like that, that's my first thought. I'm willing to bet this patient has pseudothrombocytopenia. Plavix will affect platelet function. It should not affect platelet number. And as you saw, diagnosing the pseudothrombocytopenia is a very simple thing. And you may not, change anything, because if you can show that your platelet count is 124 because we see clumping, then the actual number is probably normal. So I agree. I don't think you should worry. You just have to monitor it. That's all.
Okay. Then also, I have been donating whole blood until taking a break during the COVID pandemic. Should I stop donating blood, or should I start again?
No, I think you should start again. It's very nice of you. There's always a shortage of blood, so I think it's very admirable that that you do it on a regular basis, and I wouldn't let the COVID interfere with that.
Okay. If platelet count in the 65 area after a few tests, is it less likely to be pseudothrombocytopenia?
That's a good question. I have seen lower counts and pseudothrombocytopenia, but I would think probably not. I would sometimes patients with ITP, they have a spectrum of this of platelet count. In other words, you have some patients with ITP where the count is just a little bit low, and then you have all the way to counts in the teens or single digits. Not many conditions do that. ITP is one of them, and I think patients with like very, very severe blood diseases like acute leukemia and patients who have gotten very aggressive chemotherapy will see platelet counts in the teens and single digits, but it's very unusual for other causes. But if something's around 65, it could be a ITP that's pretty well compensated, because at 65, I would not anticipate any clinical manifestations. May bruise a little easily, but outside of that, I don't think so. And one thing I failed to mention was that there's no really test for ITP. it's really what we call a diagnosis of exclusion, meaning that the patient, the white blood cell count should be normal, the hemoglobin should be normal. When you look at the blood smear, all you should see are just a decrease in the platelet count. Some people recommend testing the blood for antibodies against platelets, but I find them very confusing, and I don't think they're very helpful. So I think it might be, I would put my bet on a well-compensated case of ITP.
Then another question, this person has ITP, they take Tavalisse, and the numbers was steady around 100,000 for the last 7 months, but it's now gone down to an average of 80,000 in the last 2 months. So does this show that their body is no longer responding as well, and the platelet count or the platelet level will continue to decrease?
That's a good question. I think you just have to monitor it. Sometimes it'll fluctuate, but I wouldn't be surprised if eventually the Tavalisse will stop working. And that's common with most of these. I would say most of them, but a lot of these drugs, eventually the body somehow gets around it, and the platelet count will drop again. But 80,000 is a pretty good number.
Okay. And then the follow-up question is, what's next if Tavalisse stops working?
Well, there are some newer medications that are coming down the pike. That may be something to look into. I have some patients that get the IVIG on a regular basis. Some may need to get it once every 3 months. Some need to get it every 6 weeks. So there are still a few options, and there's always the option of taking the spleen out. No one likes to undergo surgery, but that's certainly something that is possible if nothing else seems to be helping.
Okay, sorry about that. I think I got disconnected.
Yeah, sorry.
And also the sound cut out.
Yeah, that's when when the phone rings, it'll. I don't know how to disengage my phone from my iPad. So.
And then, what is the typical length of time for remission or of remission?
That's a good question. Sometimes I mentioned earlier, like in adults, sometimes about 10% will go away forever. A little unusual though. Most of the courses are chronic, but remission can last anywhere from 6 months to a few years is more typical.
Okay, so I think that's it for questions. So thank you, Dr. Porcelli, for taking the time to present on this topic and for answering all of our questions. And please join us for our upcoming health programs. Our next Astera Cancer class will be on June 11th at 12 p.m. The topic will be side effects of cancer therapies. For more information or to register, check the library's event page at ebpl.org/calendar. And thank you everyone for joining us for today's talk. Take care and stay safe. Thank you. All right, thank you. Take care.
Bye-bye now.